This is first our lectures which we talk about genetic ultrasound, and we start serial lectures to talk in details about advanced ultrasound fetal medicine. First, important you must understand by term genetic ultrasound. What's the definition of genetic ultrasound? What's criteria of genetic ultrasound? What is recommendation for genetic ultrasound? And this is important to enter in details in many lectures next about every organ system anomalies and trisomy syndromes and ultrasound soft markers. Genetic ultrasound definition is very important. Genetic ultrasound requirement, genetic ultrasound criteria. It's very important with lectures. Genetic ultrasound, this is lectures. And we hope by these lectures, after we finish it, to give us more informative tools for evaluation of high-risk pregnancy, high-risk fetus, to take good decisions about terminations, about continuing fetus, time of delivery, Doppler study, and so on. Genetic ultrasound. Genetic ultrasound is a technique in which fetuses are examined for anatomical defects that have been associated with an abnormalities. A genetic or level 3 ultrasound specialized evaluation of the baby performed by maternal fetal. Genetic ultrasound recommendation. Recommended for women who have a family history of genetic disorder, previous child genetic abnormality will be over 35 at the time of delivery, have a chronic illness, have exposure to certain medications or chemicals, have abnormal clinical or genetic ultrasound requirement, detailed knowledge of fetal anatomy and development, experience with birth defects and genetic disorders, expertise in counseling and the management of specific genetic disorders, proficiency using color flow Doppler, proficiency using 4D high resolution ultrasound. Genetic disorder is one of the most informative tools in high risk pregnancy. A high resolution ultrasound used to provide detailed fetal anatomy and uterine contents. The examination includes measurement of the fetal head, abdomen, extremities, and other structure. The doctor also examines and describes fetal organs, including appearance of the brain, appearance of the lungs and the fourth chamber view of the heart, detailed examination of extremities, appearance of the diaphragm, appearance of the stomach, kidneys, and the urinary bladder. Finally, the placenta is measured with its size, appearance, position, amniotic fluid, number of umbilical vessels, umbilical cord, and so on. Cervical os, and all this exam and genetic ultrasound. This is illustrations in some abnormalities associated with increased risk for Down, like increased knuckle translucency, tricuspid regurgitation, VSCD, hyperechogenic bowel, double bowel sign with atresia, pleural effusions, dilated lateral ventricles. This is major sound marker as we talk. Ultrasound levels. Level 1 is a basic ultrasound. Level 1 documented the baby's heart rate, measuring size of the fetus, ultrasound biometry, general overview. Level 2, we look for things like left palate, heart defects, neurotube defect, IUGR, and Doppler study, and more details. Level 3, ultrasound, presence of fetal abnormalities such as ones seen in Down syndrome. Ultrasound markers. What we mean by ultrasound markers? What types of ultrasound markers? Type ultrasound markers: major or hard marker, structural abnormalities, karyotype if isolated, minor soft markers, karyotype if associated with other findings. These two types, and minor, soft, and hard ultrasound markers. For every organ system, we see major, hard, and minor soft ultrasound marker. CNS, we see ventriculomegaly, holoprosencephaly, microcephaly, dysgenesis of corpus callosum, abnormal posterior fossa Dandy-Walker complex. This is major hard ultrasound marker. Minor soft, choroid plexus cyst. Musculoskeletal, we see hand and feet anomalies, syndactyl, clinodactyl, clenched fist, radial ray aplasia, club foot, and rocker bottom foot. Minor marker, short, long bones. Face, hard markers, cleft palate, lips, micrognosia, microglossia, hypo and hypertelorism, low seat ears, and small ears. Neck, we see major markers like cystic hygroma, minor like knuckle fold thickening. Cardiac, we see major like endocardial cushion defect, VSD, hypoplastic left hand syndrome, tetralogy of Fallot, and other complex anomalies. Minor like echogenic focus within heart. In GIT, we see major heart marker like esophageal angiodental atresia, small bowel obstruction, diaphragmatic hernia, omphalocele. Minor like echogenic bowel. Genitourinary, moderate to severe hydronephrosis, spastic renal disease, and renal agenesis. Minor like renal pyrectasis. Others, IUGR in second trimester hydrops. 2 fissile cord, single umbilical cord. This is definition of soft ultrasound marker. Soft ultrasound marker are minor ultrasound abnormalities considered variants of normal which do not constitute a structural defect. They may be associated with chromosomal or non-chromosomal abnormalities. Soft markers include those associated with increased risk of aneuploidy and in some cases non-chromosomal problems like knuckle translucency, nasal bone hypoplasia, knuckle bud edema, echogenic bowel, echogenic focus in the heart, choroid plexus cyst, mild ventriculomegaly. Soft marker, those associated with increased risk of non-chromosomal abnormalities when seen in isolation. Mild renal pyrectasis, single umbilical artery, enlarged cisterna. Those of undefined association like clenched fists, rocker bottom feet, sandal gap, strawberry shaped skull, short. Minor markers, white iliac crest angle more than 19 degree, brachycephaly, frontal lobe shortening, abnormal short air length, flat face, clinodactyl, hypoplasia of middle phalanx of the fifth digit, sandal gap of grade 2, semi-increase, small. Final remark, detection by ultrasound depends on personal experience of the operator, depend on proper timing of the scan, depend on the mother's, its obese, thick abdominal wall, distended abdominal gases. Proper timing of the scan is very important. As we see in large gestational age, it is difficult to scan because large organs, the proportion to each other, decreased amount of amniotic fluid, may be improper position of the fetus, face down, and so on. This is proper time is between 20 and 10 scans. Disadvantage of soft markers. The exact significance of ultrasound soft markers is still uncertain. This is operator dependent, therefore may be missed. The detection of soft ultrasound markers requires training and high resolution ultrasound equipment. The counseling, training, and expertise required is currently difficult to achieve. Some soft markers are transient and significance uncertain. With better equipment, more markers may be more evident, which may cause more concern to be prospective parent. Unless caution exercise is combined with other markers for abnormalities, may lead to unnecessary intervention. Screening scan, 16 to 20 weeks. What we do, screening scan for every fetus, every mother we do. Look for knuckle fold, echogenic bowel, ventriculomegaly, echogenic cardiac focus, choroid plexus cyst, single umbilical artery, large cisterna magna, renal pyrectasis. We must look for this if breast. Knuckle translucency. Knuckle translucency, this is normal knuckle translucency, this is abnormal knuckle translucency. It is maximum thickness of the subcutaneous translucency between the skin and the soft tissue overlying cervical spine, this area. Maximum thickness between the skin and soft tissue overlying cervical spine. This is abnormal increased knuckle translucency measured between 11 and 14 weeks of pregnancy. It is a soft marker of screening for chromosomal abnormalities, trisomy 18 and 21. Thoracic compression, diaphragmatic hernia, cardiac abnormalities. This is knuckle translucency association. Differential diagnosis knuckle translucency, cystic hygroma thickness. This knuckle translucency between two white lines, skin and soft tissue overlying cervical spine, is 5 mm knuckle translucency to the others. This is 3-way of wrong measurement of knuckle translucency, and this is right way from white line to the other. This is knuckle translucency 2 mm, knuckle skin fold, knuckle pad thickness all fold. It is the skin thickness in the posterior aspect of the fetal neck. It should be measured between 15 and 20 weeks of gestation. This is second trimester form of knuckle translucency. It's found in about 0.5% of the fetus, and it may be of no pathological significance. Sometimes associated with chromosomal defects, cardiac anomalies, infection, genetic syndromes, isolated knuckle edema. The risk for trisomy 21 may be 15 times the knuckle fold. It is second trimester form of knuckle translucency between these two calibers. Knuckle fold 6 mm or more significant. For structure survey must be done. If it's more than 6 mm, sensitivity for Downs 43% warrants karyotyping even if knuckle edema or fold of more than 6 mm, as we see in second knuckle fold. This is very important. Another image. Increased knuckle translucency, knuckle bed thickness 6 mm or over. This is knuckle bed thickness, increased knuckle translucency, and this is knuckle bed thickness width. This is 15 weeks gestations, and without scanning 6 mm knuckle translucency. Chorionic villus sampling study of this fetus revealed routine. As we see, after termination, this fetus lose edematous skin over the neck, accounting for knuckle translucency scanning. This is knuckle translucency between two calibers, between two white line distance. First distance 6.3, second distance 0.15 centimeters. This area. This is skin thickness. This is area of knuckle translucency. Echogenic bowels. What we mean echogenic bowel? Pale bowel, as echogenic as bone. Commonest to cause intra-amniotic bleeding associated with renal failure, trisomy 21, infection, cytomegalovirus, fibrosis. Hyperechogenic bowel found about 0.5% of fetus, usually if no pathological significance. But for isolated hyperechogenic bowel, the risk of trisomy 21 may be three times the background. This we see echogenic bowel like density of bone. This is bone of the spine view. This is 5 image of echogenic bowels. Echogenic bowel, echogenic bowel, echogenic bowel, echogenic bowel, and echogenic bowel. Like density of bone, as we see in spine. Association with aneuploidy. There is high risk of association with trisomy 13, 18, and 21. This is echogenic bowel. Association with structural abnormalities. Echogenic bowel has been associated with increased risk for cystic fibrosis, congenital infection, cytomegalovirus, herpes parvovirus, rubella, varicella, toxoplasmosis. Intra-amniotic bleeding, congenital malformation of the bowel, prenatal complication including IUGR. Choroid plexus cystis, sonographically fluid field small cyst less than 3 mm in the choroid plexus, within the lateral cerebral ventricles. It's seen in 1 to 2% of the fetus scanned at 16 weeks and will be almost always 24 to 26 weeks. Isolated choroid plexus cyst 0.7 to 3.6 of normal fetus, no pathological significance. Isolated CBC with no other abnormality calls for no intervention. 2.3% risk of chromosomal abnormality. They are more associated with trisomy 18 Edwards than trisomy 21 Down. In chromosomally normal babies, association with structure may be seen. This is choroid plexus cyst, small fluid field sac or cyst present in the. This is choroid plexus cyst, may be unilateral or bilateral, single or multiple, 3 to 10 mm, regress by 6 weeks. This is 3 image of choroid plexus cyst. This and this is 3 choroid plexus. Whole prosencephaly, it is major ultrasound marker. Hard ultrasound markers warrant karyotyping. This is one of the 3 fluid in brain. We see H whole prosencephaly, H hydrocephaly, H hydranencephaly. We talk later on in details. A lobar whole prosencephaly at 10 weeks, trisomy 18, found in this fetus with a lobar encephaly. A large cisterna magna, if the cisterna magna is subjectively increased, a measurement should be taken. An isolated enlarged cisterna magna is not an indication for fetal karyotyping. With an enlarged cisterna magna, expert review is recommended for follow-up ultrasound and possible imaging modalities like MRI and investigations. This is enlarged cisterna magna, as we see in this image between two. Mild ventriculomegaly. Ventriculomegaly, dilated lateral cerebral ventricle more than 10 to 12. 5% risk for lateral severe brain abnormality. 5% risk for later severe brain abnormality. 15% risk of mild problem later. The commonest abnormality trisomy 21 down and 18, 13 and triploidy. This is ventriculomegaly. We found this mild ventriculomegaly between 10 and 15. This is ventriculomegaly larger than major ventriculomegaly, large lateral ventricles more than 15. Echogenic cardiac vocus located in the chorda tendineae, not attached to ventricular walls. Moves with EV valves. 90% left ventricle, single or multiple. 95% resolve spontaneously. In high risk group, 5-fold increase for downs. Best view to visualize echogenic cardiac vocus in 4-chamber view. Search for other markers. If isolated echogenic cardiac vocus abnormality, no action. Echogenic focus should be considered normal variant. Echogenic cardiac vocus abnormalities which will be considered. Echogenic intracardiac vocus in the left ventricle of the heart. It is a vocus of an echogenic wall, small area. Echogenic small area in the vital heart with echogenicity comparable or greater than to the surrounding bone. In low risk population, most echogenic intracardiac vocus disappear by term or after a short time after delivery. Echogenic bowel like surrounding bone, echogenic cardiac vocus density, echogenicity like surrounding bone. This is as we see by 2 white arrow echogenic cardiac vocus. Short long bones, femur and humerus. Definition. Short femur and humerus length is defined as measurement less than the third centile for the gestational age. Isolated short femur or humerus length is associated with aneuploidy and should be referred for tertiary level evaluation. Short long bones may be associated with general skeletal malformation or FGR. Ultrasound screening for others. Long bone and serial growth measurement should be short femur. If the femur below 5th centile and or other measurement are normal, the baby is likely to be normal, but rather short. Rarely the sign of a dwarfism. Isolated short femur, rarely sign of dwarfism. Should not worry about this sign if isolated. Short femur found in 4 times as commonly in trisomy 21 in Down syndrome fetus compared to the normal fetus. However, there is some evidence that isolated short femur may not be more common in trisomic fetus. Short, small bones, feet and hand. Syndactyl associated with triploidy, sandal gap with trisomy 21, polydactyl with trisomy 13, overlapping fingers, rocker bottom feet, and the talibus 18. Semi-increase, one of the soft ultrasound marker of the pelvic thesis, means dilated renal pelvis 5 to 10 mm with no calcial involvement. Unilateral or bilateral. Scan for other markers. If in isolation, no further action. May indicate obstructive pathology. Follow-up scans. Predictive value range from 1 to 33, 1 to 340. Renal pelvis measurement more than 10 mm should be considered as equivalent to congenital hydronephrosis. As we see in this image, bilateral renal bilectasis, bilateral dilated renal pelvis. Mild bilectasis in this image, as the risk of Down syndrome is small. Vital bilectasis is associated with congenital hydronephrosis of zygomatic reflux. All fetus with renal pelvic measurement 5 mm should have a neonatal ultrasound and pediatric follow-up to evaluate if it is congenital obstructive uropathy, congenital peripheral junctions, or isolated renal bilectasis and will be resolved. Other anomaly, what's called two-fissile cord. The presence of two-fissile cord can be a marker of aneuploidy. It is soft ultrasound marker. This is not typically searched for in the first trimester, but this finding can be recognized in a teen weeks fetus. one would look for a two-facial cord if the fetus has other findings, such as thick knuckle lucency, for instance. Association with structure anomalies, an isolated single umbilical cord has been associated with cardiac, renal anomalies, and fetal growth restriction, FGR. 0.2 to 1% of pregnancy present with a two-facial cord. Among this, about 1 to 10% have an aneuploidy, including trisomy 18, 13, triploidy, and X. As we see in this image, color Doppler and inner Doppler demonstrate two-facial cord in a teen-week fetus. Single umbilical cord in this image, as we see by arrow, this is cord. As a single umbilical cord, imaging by beam mode and the color mode and constructive image, as we see, this is artery, black arrow, 0.28, and vein, white arrow, and single artery, colored and related to urinary. Short fetal air length. Also, short fetal air length may be a marker of fetal aneuploidy. Adequate evaluation has not been undertaken to establish its usefulness as either a screening tool or as a part of panel for markers for tertiary centers. Use of fetal air length remains relegated tools. As we see in these three images, flat air, slightly protruding air, markedly protruding curved air, in one of the soft ultrasound congenital anomalies. This schedules air length related to gestational age in healthy fetus and aneuploid fetuses, flat airs, slightly protruding airs, markedly protruding airs, curved airs. This is many factor, 4 factor, as we see in healthy fetus. Stroke periskull, transverse scan, as we see in this image, axial scan, flattening of the occiput with a pointed appearance to the frontal bones. 45% incidence trisomy 18, it's about stroke periskull, may be associated with skeletal dysplasia, may be normal. Major cardiac defect and uterine atresia, both warrants karyotyping, as with double bubble sign of uterine atresia, and this is major cardiac defect. This is current concepts about fetal nasal bone. It is one of the ultrasound marker, as we see in Down syndrome. Hypoplasia, and this normal. Hypoplasia of nasal bones, and this is normal nasal. This is nasal bone present, as we see 3 white line, 2 white line by head of arrow, it's a skin, 3rd line by arrow, this is nasal bone. Nasal bone seen by this white arrow. Nasal bone absent, and in this image, nasal bone absent, 2 white line, as we see in this is skin, nasal bone absent. Small nasal bone, as we see in this white arrow in Down syndrome, this is small white dot lines, is small nasal bone absent or small nasal bone indicative of Down syndrome. 15 to 20 weeks hypoplasia, 70% Downs, 1% normal. Nasal hypoplasia has not been associated with other aneuploidy. Absence or nasal bone hypoplasia has not been found to be associated with structural abnormalities, even when isolated warrants karyotyping. Bone, central cleft palate and lip, as we see by the double bubble. This is also one of the ultrasound markers. Double bubble, uterine atresia, double bubble signs. 30 to 40% of risk trisomy 13 and 18. Clinodactyl imaging of the outstretched hand to evaluate for 5th finger clinodactyl. It's not an expectation during the 16 to 20 week ultrasound. 5th finger clinodactyl is associated with trisomy 21 and should be considered for research or tertiary level. Increased iliac angle. Increased iliac angle is a possible marker for trisomy 21. However, measurement techniques don't make it amenable to screening examination, and it has not been evaluated to be effective in a low-risk population. This marker may be useful for tertiary centers investigating high-risk patients or as a possible vectors. Sandal gap, no further investigation or follow-up are necessary if isolated sandal gap are detected, one of the ultrasound soft markers. It is not part of the we talked about screening ultrasound before. Tight amnion, when amnion is too close to the fetus in which the gestational sac is predominantly occupied by the extra amniotic column, and the amniotic cavity is tightly wrapped around the fetus. as we see in this image. Those fetus are often at risk of trisomy 16 or triploidy, as we see in this image. Amnion very tight opposite about this embryo. The embryo later miscarried and was identified as trisomy. Yolk sac anomalies. Several papers demonstrate that an irregular yolk sac, too large yolk sac, are factors that are predictors of pregnancies that will end up as miscarriage in the first. Major structure anomalies. The presence of certain major structural anomalies should also prompt a karyotype. At 9 and 18 weeks, one appeared to have an omphalocele greater than the normal physiological herniation of the guts and had trisomy 18. The other one had a large obstructed bladder and a small omphalocele and indeed have trisomy 13. Last had a lobar holoprosencephaly, also seen with trisomy 18. This about association of some major structural anomalies with congenital or chromosome. As we see omphalocele at 9 weeks in this fetus associated with trisomy. Omphalocele, as we seen, cystic hygroma warrants karyotyping. It's one hard ultrasound soft markers. Megacystis, enlarged urinary bladder, pointing and pinhole sign seen in posterior urethral valve, as in this image, enlarged urinary bladder. This is in this fetus seen associated and may be isolated. Shapeless embryo is an embryo with no distinctive head and the body at time when this finding should be recognized. This can be a sign of very serious trisomies, usually very lethal trisomies such as trisomy 8, 16. Wide iliac crest, one of ultrasound soft marker. And this schedule, as we seen, denotes prevalence of the fetal chromosomal defect in fetus with isolated and multiple abnormalities. Ventriculomegaly, holoprosencephaly, choroid plexus, cystis, posterior fossa cyst, cleft palate, facial cleft, macrognesia, cystic hygroma, knuckle edema, diaphragmatic hernia, heart defect, general atresia, exophthalmos, talibus, growth retardations. We hope in these examinations to give in informations or multiple information about genetic ultrasound, about ultrasound soft marker, ultrasound hard marker, enumerate. We must be aware of it, its significance, and we complete in the next lectures about some chromosomal abnormalities, trisomies, and syndromes, and how we diagnose it.